Welcome! In this explainer, we are going to take a deep dive into pulmonary function tests. We'll be systematically breaking down all the data we get from spirometry and diffusing capacity tests to build a really solid framework for diagnosing lung disease, focusing on the core physiological principles behind it all.
Okay, so here's our roadmap. We're going to start with the absolute fundamentals, the language of the lungs, you could say, their volumes and capacities. Then, we'll get into the actual spirometry test and its graphs, apply that to diagnosing both obstructive and restrictive patterns, and then pull it all together by adding in the diffusion test to get the complete diagnostic picture.
All right, before we can even start to interpret any of this data, we have to master the basic vocabulary. We'll start with the 4 primary lung volumes. Think of these as the fundamental building blocks that can't be broken down any further. First up, we have tidal volume, or TV. This is pretty simple. It's just the amount of air you're moving in and out with each normal, quiet breath when you're just sitting there. For a typical healthy adult, that's about 500 milliliters.
Next is the inspiratory reserve volume, or IRV. So after you take a normal breath in, the IRV is all that extra air you can possibly suck in if you try as hard as you can. It's a pretty big reserve, usually around 3 liters.
And on the flip side of that, you have the expiratory reserve volume, ERV. This is the exact opposite. After a normal, relaxed exhale, it's all the additional air you can forcefully push out of your lungs. This is usually about 1 liter.
And finally, there's the residual volume, or RV. This is the air that's always left in your lungs, even after you've blown out as hard as you possibly can. It's super important because it keeps your tiny air sacs from collapsing. But here's the crucial part. Because you can't exhale it, you can't measure it with a simple spirometer. Okay, so now that we have those 4 basic volumes, this is where it gets really interesting. We start combining them to get what we call capacities. Now look closely at the functional residual capacity, or FRC, and the total lung capacity, or TLC. See how they both use that unmeasurable residual volume? Well, that means you can't measure them with simple spirometry either. You need more advanced stuff for that. For our purposes, the most important one on this list is the forced vital capacity, or FVC. That's the total amount of air you can possibly blow out after taking the deepest breath you can.
All right, let's talk about the spirometry test itself. A modern spirometer doesn't just give you a bunch of numbers. It gives you 2 essential graphs that let us actually see what the lungs are doing mechanically.
So the machine spits out 2 key pictures. First, there's the volume time graph, which, just like it sounds, shows how much air you breathe out over a few seconds. Then you have the flow volume loop. This one's a little different. It plots how fast the air is moving against how much volume you've already breathed out. Each one gives us a unique and really valuable piece of the puzzle.
Now, out of all this data, there's one single calculated number, one key ratio, that becomes our first major clue. It's the first decision point in our whole diagnostic algorithm, and it's what starts to separate lung diseases into 2 big buckets. And here it is, less than 70%. This number is the smoking gun, the diagnostic hallmark that basically screams obstructive lung disease. The obvious question then is, what is this a ratio of?
It's the FEV1 to FEC ratio. So, FEV1 is the forced expiratory volume in 1 second. Basically, how much air you can blast out in that very first second. In a healthy person, you should be able to get at least 80% of your total lung capacity out in that first second. When that ratio drops below 70%, that is the definitive indicator of an obstructive problem.
So that sub 70% ratio points us straight toward the obstructive diseases. And in conditions like COPD or asthma, the fundamental problem isn't about getting air in. No, the real struggle is getting all that air back out.
So what's actually going on here? Well, a lot of the time, it's something called dynamic airway compression. In a healthy lung, you have all this elastic tissue that acts like scaffolding, holding your tiny airways open when you breathe out hard. But in a disease like emphysema, that elastic scaffolding is destroyed. So when you try to force air out, the pressure just squishes those unsupported airways shut, trapping air inside.
And you can literally see this happening on the flow volume loop. After that first blast of air, instead of a nice straight line as you exhale, you get this classic concave, scooped out appearance. That's the visual signature of those airways collapsing and cutting off the airflow way too early.
But what if that FEV1 to FEC ratio is normal, or maybe even a little high? Well, that pretty much rules out an obstructive problem and immediately points us toward our second big category, restrictive lung diseases.
Here, the problem isn't about airflow at all. It's about the lungs being stiff or compressed, so they just can't inflate to their normal volume. And when you look at the flow-volume loop in a restrictive disease, it's fascinating. The overall shape is perfectly normal. It looks just like someone took a healthy loop and just shrunk it down. It's this perfect miniature version, which is a dead giveaway that the underlying problem is a global reduction in lung volumes, specifically a low FVC.
So let's just nail this down, side by side. Obstructive disease is defined by that low FEV1 to FVC ratio. Restrictive disease, on the other hand, is defined by a low FVC, a low total volume, but the ratio itself is normal or even high. And the graphs tell the story visually: scooped for obstructive, miniature for restrictive.
Okay, so we can tell obstructive from restrictive, but to refine our diagnosis even further, we need to look beyond the simple mechanics, the so-called bellows function of the lungs. We need a test that measures the whole point of breathing, how efficiently gas gets transferred into the blood. And that brings us to the DLCO test. It stands for the diffusing capacity of the lung for carbon monoxide. This test is all about checking the health of that critical interface between the air sacs and the blood vessels. We use a tiny, completely safe amount of carbon monoxide because it has this crazy high affinity for hemoglobin. By seeing how much of it gets picked up by the blood, we can get a really precise measure of the lung's overall gas transfer capacity.
Now, this is where the DLCO really shows its power. It helps us tell apart diseases that can look almost identical on basic spirometry. For instance, think about obstructive diseases. A low DLCO points right to emphysema, where you're actually destroying the lung surface. But in asthma, the DLCO is often normal or even high. Same thing for restrictive diseases. A low DLCO suggests the problem is in the lung tissue, like with interstitial fibrosis, but a normal DLCO tells you the lungs themselves are probably fine. The restriction is coming from outside, like a chest wall problem or a neuromuscular issue.
Okay, let's put it all together now. We can synthesize everything we've talked about into a single, step-by-step diagnostic algorithm. This flowchart is really the key to systematically interpreting PFTs.
So here's the entire process broken down. Step 1. Check the FEV1/FVC ratio. If it's low, you've found an obstructive disease. End of story for that step. If it's normal, you go to step 2. Check the FVC. If the FVC is low, you're dealing with a restrictive disease. And finally, step 3 is where you bring in the DLCO to pinpoint the problem. A low DLCO helps you zero in on issues inside the lung tissue or its blood vessels, while a normal DLCO points to problems outside the lung parenchyma itself.
You can see how this whole framework lets us read the lungs with remarkable precision, but it leaves us with one final thought. If spirometry tells us the story of the mechanics, the plot of how we breathe, then the DLCO reveals the story's deeper meaning. It gets to the very heart of the lung's ultimate job, the efficiency of gas exchange. And to really understand a patient's whole story, you absolutely need to integrate both.